So, ladies and gentlemen, dear colleagues, it's really a great privilege and pleasure to highlight diabetes-related aspects of this exciting symposium on Hfpef. My disclosures in trials, but also a recent editorial on heart failure at the crossroads of cardiology and diabetology. So, first message. Cardiorenal complications are by far the most common first manifestation of cardiovascular complications in type 2 diabetes. These are all with the blue lines in all the countries of this international trial. And as you can see, heart failure contributes around 40% to this first manifestation of cardiovascular complications. And the presence of heart failure means really bad news in terms of all-cause death, which is up more than twofold. Presence of cardiorenal manifestation, it's more than 3. And in terms of cardiovascular death, it's actually threefold increased risk for cardiovascular deaths and fourfold with cardiorenal events. Looking over a lifetime, this is another contemporary huge database from UK. The main notions are 4 out of 5 patients at the end of the day will be diagnosed with CVD or CKD or die of cardiovascular causes, and 3 out of 10, patients will be diagnosed with heart failure over their lifetime. Well, looking at the full spectrum on the left side, the cardiovascular renal disease free at the study entry, you see 80% of, at the end of the day, will suffer from major adverse cardiorenal events. If you start at entry with heart failure already, you see the highest risk for cardiovascular death, similar risk for chronic renal disease, and all around 90% of these major complications. In terms of starting with an MI, the highest risk for heart failure in yellow. And it has been no surprise that in the cardiovascular outcome trials, looking at incidence heart failure over time, a very striking correlation with the background myocardial infarction in the study population. But also of practical importance, renal impairment, decreased GFR or presence of albuminuria are enormous risk predictors for heart failure outcomes. The heart and the kidney speak to each other in diabetes. The heart via the natriuretic peptide system and the kidneys signal back via activation of RAS and activation of the sympathetic nervous system, and you can create some vicious circle, actually rising up to early heart failure development in diabetes. And Hfpef, our topic here with the changes as listed, very often the earliest defect in the diabetic heart is that of diastolic dysfunction, not atherothrombosis. Now we have suggested a so-called ominous octet operating in diabetes, driving the heart across the diabetes risk continuum all the way to development of heart failure, hospitalization, and cardiovascular death. And central, like in people without diabetes, coronary artery disease, ischemic heart disease, hypertension, but then more diabetes-specific factors like cardiometabolic myopathy, cardioneuropathy, microangiopathy, and the kidney signal in terms of fluid expansion and glomerular hyperfiltration, and to mention activation of sympathetic nervous system overdrive. Well, if you are missing the effect of hyperglycemia, yes, it is a predictor, as in this huge Swedish database, the red line, but the disappointing, and this is another important message, intensification of glycemic control in the so-called mega trials as listed here was not successful in reducing heart failure events. Now, however, this may be due to the kind of therapy used at the time, which consisted out of a lot of insulin use, also TZDs and sulfonylureas. And of course, today we wouldn't recommend this kind of therapy anymore, especially glitazones, fluid retention, sodium retention, but similar also with insulin and the sulfonylureas are connected with risk of hypoglycemia, other related problems. Of course, today we build around SGLT2 inhibitors against the background of the studies listed here. However, in terms of Hfpef, we have to review for a moment the current definitions of Hfpef, signs of symptoms, of course, and left ventricular ejection fraction above 50. Then there is a mildly reduced ejection fraction, 41 to 49, and Hfref below 40. Now, if you look at the trials which had evaluated SGLT2 inhibitors in patients with diabetes and Hfpef, you see only the sotagliflozin study concur with the current definition of ejection fraction above 50. Others take part partially or totally, like empagliflozin study, EMPEROR preserved the mildly reduced segment of heart failure. However, overall, looking at the outcome of those trials, and the outcome is listed combination or composite cardiac death or hospitalization due to heart failure, look promising. However, the EMPEROR preserved study contribute the most, and many of the individual cell actually cross the line of unity. And so we have a closer look on the EMPEROR preserved, which showed a 21% reduction with numbers needed to treat in the low 30s. However, if you look at subgroups according to Hfpef, now this would start here, the lower segment, but the most significant input on the positive results come from Hfmref, and so mildly reduced. However, just in those days, the FDA now has approved the use of, in that case, empagliflozin, but I think it's very similar for all the other SGLT2 inhibitors for Hfpef patients. Now, coming to the end, most importantly, watch out for heart failure in people with diabetes. Either heart failure is known, presence of CKD, risk factors, or also presence of coronary artery disease, being symptomatic or silent. Now we have to go through signs and symptoms, risk scores, and measurements of BNP, and of course, the ultimate diagnosis is based on echocardiographic or other imaging factors. And as mentioned, we center around SGLT2 inhibitors. So my last slide here, what do you think the role of the endocrinologist, diabetologist in the multidisciplinary treatment paradigm, assuring the diagnosis of heart failure, assuring compliance with the cardiologic therapy, addressing the appropriate cardiometabolic approach, including lifestyle management, some exercise training, nutrition, depending on the context, and tailoring the appropriate glucose-lowering therapy in the individual patient. And today it's centered around SGLT2 inhibitors. And of course, also very important, the interdisciplinary cooperation with cardiologists and nephrologists. Thank you very much for your attention.